Yeah, we'll shift gears now to our didactic presentation from Dr. Weitzen. I realize we're pretty short on time, so we may end up going a little bit past the 1 o'clock hour. Dr. Weitzen, does that work for you? Do you have the ability to stay on past 1?
Yes, I can stay on past 1.
Appreciate that. Alrighty, so I'll pull up your slides here and we can get started. So this is our disclaimer, just letting you know that we do record these sessions. We actually take out anything of the case presentations and strictly keep it this didactic portion. But if you don't want to be on the video, let us know, send me something through the chat box and we can edit you out. And then Ricardo did a great job of this today, but this is just a reminder that if you do present a patient case, please just don't disclose any protected health information. This is our team and our disclosure policy, just letting you know that none of the team members have any relevant disclosures to make. And with that, I'll turn it over to Dr. Weitzen.
You'll advance my slides, is that okay?
Yes, I will.
Okay, so I'm going to talk about medication for opiate use disorder, and in particular for women of reproductive age in pregnancy and postpartum. Next slide, please. So the learning objectives at the end of this session, participants will be able to define opiate use disorder, understand issues of opiate use disorder in pregnancy, and identify medications used to treat opiate use disorder. So the definition of opiate use disorder is a physical and psychological reliance on opioids, and this is a problematic pattern of opiate use that leads to impairment or distress. It's diagnosed when a person has 2 or more symptoms within the 12-month period, and the next slide will be the symptoms, and it can be diagnosed as mild, moderate, or severe, depending on the number of symptoms that the person reports. So this table are the symptoms that are common with opiate use disorder, including using larger amounts for longer periods of time, desire to cut back but not being able to, spending time trying to obtain substances using and then or recovering from substance use, craving opioids, using opioids that causes failures to fulfill obligations at work, school, or home, having recurrent social problems due to opioids, reducing your social, occupational, recreational activities, using opioids in dangerous situations, continued opioid use despite physical or psychological problems, tolerance, meaning that you take higher doses of the drug to feel the same effect or actually have a reduced effect from the same amount of drugs, or withdrawal, which is experience of pain or uncomfortable symptoms in the absence of drugs. And I would imagine this can probably be applied to alcohol use disorder as well. So, but this is the DSM requirements. Next slide, please. So opiate use disorder, in terms of the epidemiology, it's pretty serious. Overdose deaths due to opioids, they report about 128 deaths per day. That was in 2018. And they're about 4.2 per 100,000 deaths among women. And the deaths due to opioid use disorder overdose is increasing in women at twice the rate that's increasing in men. There's also non-fatal overdoses. So when you include both fatal and non-fatal overdoses, women have a higher rate of overdose compared to men, almost twice as much. And prescription opioids among reproductive women, almost 35% on average reproductive women have been prescribed an opioid in the past year. Next slide. So in pregnancy, the maternal opioid use has also gone up. So you can see in 1999, it was a little less than 2 per 1,000 live births. And in 2014, it's above 6 per 1,000 live births, and it's actually higher today. It's about 7 or 8 per live births. Next slide, please. So some of the consequences of opiate use in pregnancy, especially on the infants, is there's a higher risk of preterm delivery among pregnant women who use opioids during pregnancy. And also there's neonatal opioid withdrawal syndrome, which is a syndrome due to the fact that opioids cross the placenta while the baby is in utero. And neonatal opioid withdrawal syndrome happens because of the discontinuation of the opioid exposure after delivery. It's defined as a cluster of symptoms, including metabolic, gastrointestinal, and neurologic symptoms in the baby. The incidence per 1,000 live births is 7.3, and that was in 2017, and it's increased since then. NOWS also leads to an increase in hospital length of stay for the baby and increased healthcare costs. And it's treated with both non-pharmacologic and pharmacologic methods. Next slide, please. So today I'm going to talk a little bit about the medications that are available for opiate use disorder. It's been called medication-assisted treatment, but we're currently shifting to be calling it medications for opiate use disorder. The overall purpose of MOUD is to control withdrawal symptoms, decrease cravings, and block the effects of opioids. And if it's effective, it's been found to decrease any opioid use, increase treatment retention in substance use disorder treatment, decrease HIV and hepatitis C transmission, and decrease criminal activity. Next slide, please. So the first drug I'm going to talk about is Naltrexone. So Naltrexone is a non-opioid, non-addictive, and medication that can be dispensed or administered in a general medical setting. It has no abuse or diversion risk. It's administered by a monthly intramuscular injection, so patients only need to get it once a month. It works by blocking receptors, so it blocks the euphoria and sedating effects of opioids, which helps decrease cravings. Some of the requirements is that patient must detox from opioids prior to starting on naltrexone. This means 7 to 14 days of going through withdrawal symptoms. Common side effects of the medication are nausea, sleepiness, dizziness, decreased appetite, pain, and increased overdose risk. And that's because patients who decide that they're going to return to use of opioids will need larger quantities of opioids in order to get the same effect that they were getting before when they weren't on the naltrexone. Naltrexone is not for patients who are less than 18 years old, and it is not recommended for use in pregnancy. And as I said before, it can be administered in general medical practice if available. Next slide, please. So the next medication is buprenorphine. Buprenorphine is a partial agonist, so it binds to the receptors more strongly than other opioids, and this helps reduce cravings, withdrawal symptoms, and the euphoric effects of opioids. It comes in oral preparations where you put it under your tongue, and it's absorbed by the mucosa. Most preparations are in combination with naloxone, except for Subutex, which is just a buprenorphine-only preparation, and this is used only in pregnancy for the most part. There are other preparations that there's less known about. There's an implant of low-dose buprenorphine that patients can get every 6 months. And there's also a depot injection that you can get monthly that can administer higher doses of buprenorphine. One of the great things about buprenorphine is that it can be prescribed by a primary care physician, OBGYN, a psychiatrist, or nurse practitioners, physician's assistants, and nurse midwives. But it does require a waiver and additional training. In addition, when you prescribe buprenorphine, because it's a narcotic, you are, as a practitioner, required to check the prescription monitoring program to make sure that there's no additional prescribing of other types of medications, opioids, or medications that might interact with buprenorphine that could cause higher risk of overdose, such as benzodiazepines. Next slide, please. So just a little bit more about buprenorphine. 24 milligrams is the highest effective dose. You must be in withdrawal before starting or else will precipitate withdrawal. And usually withdrawal is measured by the clinical opioid withdrawal scale, or COWS. Some side effects of this medication include constipation, headache, nausea, vomiting, sweating, and severe side effects include respiratory depression. This medication needs an induction period, and inductions can be done on an outpatient basis, either in the clinic or at home, or inpatient or through the emergency department. In pregnancy, for women whose gestational age is less than 22 weeks, you can be induced as an outpatient. For greater than or equal to 22 weeks, inpatient induction with fetal monitoring is recommended. And buprenorphine is safe in breastfeeding. Just a bit about naloxone. So naloxone, in combination with buprenorphine, it's a 4-to-1 ratio. Naloxone is an opioid agonist. Most people have heard of it as being used to reverse effects of opioids in overdose by binding to the opioid receptors very quickly and kicking the opioid out of those receptors and thus reversing the effect. It's primarily inactive in combination with buprenorphine unless it's injected. So it's actually a deterrent for injection of buprenorphine or the combination of buprenorphine and naloxone. It's not well studied in pregnancy, and therefore we tend to use buprenorphine only in pregnancy, not in combination with naloxone. However, the combination product is okay after delivery, and it's okay in breastfeeding. Next slide. Finally, the third medication that's used for MOUD is methadone, and this was the very first medication used for treatment of opiate use disorder. It's a long-acting opioid agonist, and it occupies receptors and blocks the effects of opioids. It needs to be taken daily. The typical dose is between 60 and 100 milligrams per day. It's only available through certified treatment programs, so primary care and other physicians cannot prescribe methadone for opiate use disorder. Usually patients start with daily dosing, and usually it comes in combination with behavioral health services. Side effects include restlessness, nausea, vomiting, itchy skin, constipation, prolonged QTC waves on EKG, and dyspnea, chest pain, palpitations, and confusion are some of the serious side effects. Methadone is safe in pregnancy, it's safe in breastfeeding, and one of the ways that we monitor the effects of this is to do monthly EKGs to make sure patients aren't developing heart problems. Next slide. So treatment maintenance. So we see these patients frequently. We monitor their progress by doing urine drug screens, as well as asking patients about their successes and challenges in treatment. We also limit the supplies of these medications, which brings the patients back for frequent visits. And oftentimes these visits can be combined with primary care, prenatal care, or behavioral health visits, which work best so that a patient isn't trying to go to multiple appointments. And behavioral health treatments such as MI, CBT, and peer support have been found effective as well in combination with MOUD. Next slide, please. So these are a bunch of resources and references. The PCSS support, the Provider Clinical Support System, is an amazing resource. It has lots of didactics, webinars and things like that about every topic you can possibly imagine with substance use disorder. Most of the data that I presented today was from the Centers for Disease Control and Prevention. SAMHSA is another great resource for finding providers who provide medication for opiate use disorder. NIDA is the Institute of Health that does most of the research on opiate use disorder. This Orman article is a great review about Suboxone, and the APA is the one that provides the DSM-5 diagnosis for opiate use disorder. Thank you.
Excellent, great information. Thanks for that, Dr. Weitzen. We'll open up to the group right now for any questions. Ricardo, one of your questions from your case form was addressed in there. So the PMP, the Prescription Monitoring Program. So Dr. Weitzen, could you maybe talk about the PMP a little bit more and how that's useful for providers?
Yeah, so I'm not exactly sure how it works sort of on the other side of it, but I know that at least in New Mexico, all prescriptions that are either Schedule 2 or 3 prescriptions, which include opioids, narcotics, stimulants, medications like Lyrica or pregabalin, benzodiazepines, insomnia medications. When a prescription is written and filled, the pharmacy reports that prescription's filling to this body called the PMP. And so, and that allows the physician to go in and look and see what other prescriptions have been filled by that particular patient, so that they can determine whether there's been some inappropriate filling. For instance, if a patient is doctor shopping and has gotten opioids from one doctor and then gotten other opioids from another doctor and things like that. So it helps kind of monitor the medications or the prescriptions that patients have received from different providers. I believe every state in the country now has a PMP. For physicians or anybody who's prescribing controlled substances, you must check the PMP at least every 3 months on your patient. At least in New Mexico, that's the rule, and if you don't do it, then you could lose your prescribing license.
Excellent, thank you. Dr. Kammerer shares some comments here. I don't believe there's any contraindication to performing outpatient induction on buprenorphine across all gestational ages. No need for inpatient if greater than 22 weeks gestation. Additionally, there's evidence that naloxone in the combo product does not have any issues, so can use either buprenorphine or buprenorphine combination naloxone.
Yeah, I think, well, I'm not, let me speak to the combination. I believe that that's true. I think originally it was only pregnant women were only studied using just the buprenorphine. And so I don't know if there's been any randomized clinical trials regarding buprenorphine and naloxone. But I do know that in our practice, we are using the combination product. In terms of the gestational age, so I no longer deliver babies and have a limited opportunity to do prenatal care for patients who have substance use disorder. I know in our program, we definitely have patients come in because of at 22 weeks because of the viability of the fetus and the effects, the potential traumatic effects on the fetus of withdrawal syndromes in the mom. So that's why we have them come into the hospital to observe them. It's not so much the induction, it's more the withdrawal.
All right, thank you so much, Dr. Camier. Any other questions from the group before we move on to some resources that we want to share with you?
For the buprenorphine, is there a form that's more easily abusable? For example, we have a family that was on the sublingual ones, but now want tablets, and well, they're a little sketchy family.
Yeah, so I think the tablets are more, well, I think I think the tablets are easier to do things like grind them up and snort them. I'm not sure how much better of an effect in terms of like the high or the euphoria that one would get from snorting. So I'm not really sure, especially if it has the naloxone in it. What I've noticed is that there are a lot of people who do request to have just the buprenorphine and will say that, especially women who have been on just the buprenorphine and then are switched to the combination product will complain about headaches and things like that once that they've switched, and asking for the buprenorphine alone, even though it's it's not really indicated. So that also is sort of a potential for abuse, is when somebody's getting just the buprenorphine alone when they're not pregnant.
In that case, when they're saying, hey, I'm having headaches, I want to go back, would I want to reassure them and be like, well, give it time, it's part of getting used to the new medicine?
What I do is I switch from, especially since the buprenorphine is tablet alone. So if they've gone from buprenorphine to buprenorphine naloxone tablets, I'll say, let's try the strips, or let's try a different manufacturer of the strips or whatever. So yeah, I definitely try to reassure. I think our pharmacy at UNM is really good at saying, like, if you're not pregnant, you're not getting this. So so then it's just like you're either going to take the combination or you're not going to get the Suboxone. So
Thanks, Dr. Dalton. All right, I'll pull up some last few slides here that Christina is going to present for us, just about some available resources that we wanted to share with you all.
Thank you, Troy. I'll unmute myself. It's easier for y'all to hear me. Just wanted to just highlight again some of the wonderful resources that you have there in Nevada. So one is the Adopt SBIRT. I think we've talked about this before. Lots of good resources on trainings, TA support, things like that. If you can forward, Troy. Also, the Nevada State Opioid Response. Again, a lot of resources on the website there. Different resources for providers, trainings, different things of that nature. And then one more slide. And then this is a wonderful resource that was put together, a guide for reproductive health complicated by substance use. And what's really nice about this guide is it really gives specific information to Nevada and specific to for women in regards to either being in the age that are pregnant or could become pregnant. So really nice information on billing and screens and all sorts of things are available in that guide. So again, these slides, I'm wondering, Troy, if we'll post these as well. So wanted to make sure that folks got at least exposed to those. We may in our next session take you to those websites, show you a little bit more about what's available there, but just wanted to highlight those resources available for folks.